My first lecture this morning is about syncope. In some ways, this is a whole new topic. In some ways, I'm going to be a broken record. It's the same old, same old, same old. It's about how in emergency medicine, one of our jobs is finding that really dangerous needle in the haystack, and how we're finally starting to realize that searching for that needle can cause harm, and we have to not only consider how important it is not to miss the needle, but also how harmful it can be if we look the wrong way. And syncope is as good an example of this as any, because it's really pretty simple, syncope, most of the time. Somebody comes in, they passed out, or they almost passed out, doesn't matter, and most of them are fine. Of the 10, 15%, depending upon what your population is, if you start with old people with heart disease, maybe more, but of the group that isn't fine, the vast majority of them are obvious right in front of you. So it's pretty easy. The ones who look sick, they have abnormal pulse, they have abnormal vital signs, they're altered, they're not normal. Those are easy. Then there's the large group who look great, and most of them, if you did nothing, would be great. So our job is to find the occasional one, maybe 1 out of 100 in that group who looks great, maybe depending upon the population, a few out of 100, but it's a small number, who actually have something really important that you don't want to miss. And now we're going to consider as well, how do you do that and not miss them in a way that doesn't cause harm? Because if you don't want to miss anybody ever, you got to admit them all and keep them in the hospital forever on monitoring, and that's crazy. So what we want to do is try to increase our chance of finding the sick one without, at the same time, doing a lot of harm to all the healthy ones. So let's go step back, and that's all this chapter is about. We're going to spend a few minutes on some details about that. But before we do, let's think conceptually again. What is syncope? Why do people have syncope? What's the mechanism? You all know this, but think about it, because it's useful to go through it in your brain. Loss of blood flow to the brain, and it's not focal, it's generalized. So when you have focal blood flow loss, you get a stroke, right? Or a TIA or something like that. You get a focal deficit because one specific area of the brain isn't working. When you get a global loss, overall the brain doesn't work and you lose consciousness. Now, so you can get that for a lot of reasons, but what's the really important reason why you get sudden, it's usually sudden, global loss of blood flow to the brain? Okay, arrhythmia. Now there's one other thing about, and that's the answer, okay? That's the key answer. If you want to know what to worry about, that's it, period. Arrhythmia. Okay, now before we go further, there's one other thing about syncope that's really, really important. It's global loss of blood flow to the brain, but there's one other characteristic that we didn't mention, which is the timing. What's the timing? It's transient. Well, yes, we're going to get back to that in a second, but it's transient, right? Because if it's not transient, it's not syncope, then it's altered mental status. Altered mental status is something very, very different. Altered mental status we deal with a lot, right? And we have to know how to work that up. We're not going to talk about that now. But this is somebody who is walking around, suddenly loses blood flow to the brain and becomes unconscious or near unconscious, and then is better again. So think about the causes of syncope in a textbook. Somebody give me a list of causes of syncope in any textbook. Hypoglycemia. Does hypoglycemia cause syncope? Absolutely not. Every time a resident sends off a sugar, I think to myself, you must not be thinking. Because how could you have a blood sugar of 20 that makes you pass out that now you're normal? What, automatically your blood sugar came up to 100? And if it magically did, it was 20 for a second and now it's 100, it will be 100 and you won't learn anything by the blood sugar. If the person's normal in front of you, their blood sugar isn't 20. And the same is true for all those many other labs. So I see lots of people getting labs that make no sense. Syncope is a transient event. It comes and it goes. So that's really important to think about that. If you have somebody who has altered mental status, it's really important to get a sodium, because there's no way clinically to tell when somebody's hyponatremic. None, zero. So if that's the cause of it, it's really critical that you know it, and you're not going to figure it out by thinking, so you get it. But there's no reason ever to get a sodium in somebody who had syncopal episode. Their sodium isn't 102. They would not be normal in front of you. So syncope is a transient event, which is why arrhythmia is the critical thing to think about. Now, there are some biggies that can cause you to pass out for a variety of reasons having to do with sympathetic tone. So you can pass out and then wake up again with a pulmonary embolism, for example, or some other major catastrophic event, and then wake up. But that patient won't be normal. They may be awake, but they're not normal. So all the textbooks, I think, get syncope all wrong, because they're writing about all these big things like ectopic pregnancy. Excuse me, ectopic pregnancy doesn't cause syncope. It causes hypovolemia. Hypovolemia causes you to fall down maybe and be orthostatic, but you're not normal. Orthostatic syncope is a separate event, and we should be able to get a history of that. And the most common cause today of orthostatic syncope is not ectopic pregnancy or GI bleed. What is it? Drugs, meds, especially in the elderly. Number 3 is the most important article in this chapter only because it reminds us of that. It reminds us that alpha blockers are given to old men all the time because of prostate issues. We're going to talk later about why that's probably not a good idea. I think it's not a good idea. I think it's more harm than good. But the reason it's more harm is because it causes syncope. And diuretics also, lots of syncope. Now, there, again, you'll get a history that's different than I'm going around normal and all of a sudden I passed out. That's somebody who stood up and they passed out. That's different. But in any case, so let's go back. If we really have syncope, this person was normal, they became abnormal, they're normal again. That's a special case. That's syncope that we have to think about. And let's think about them for a second. Again, let's go back to timing. What's the timing of they were normal, then they passed out? How fast did it happen? It's sudden. It's almost always sudden. It's not they're getting worse and slowly they go, and then they pass out. If it's an arrhythmia, they may have a little bit of a prodrome, oh, I'm starting to feel funny, and then they pass out. But it happens very rapidly. And then what happens afterwards? As soon as the arrhythmia goes away, they wake up. So one of the big things is to try to distinguish syncope from seizures. There is one article in there about that, and that's the key. Seizures do not wake up right away. Now, like everything else in medicine, there are exceptions. But in general, seizures do not wake up. There's a postictal period. One word of warning, an arrhythmia that causes loss of blood flow to the brain can cause a seizure. So you can have both. But for the most part, they're pretty easily distinguishable. So again, I'm not worried about the one who now looks abnormal, because those we know what to do with. I'm worried about the one who now looks absolutely normal. And so we have to think about, could it have been an arrhythmia? And the answer is yes, it could have been. And then we have to think about, so what? So which are the arrhythmias that we have to worry about? The ones that recur, and if they recur, could be really harmful. So VTAC is a really important one. What are the signs of VTAC? There are none, okay? That's why we have to worry. Fortunately, in all the people who look normal, most of them never had VTAC. There are a couple other things that are useful that we can look for that we'll talk about in a second. But this is how I see the problem, which is those guys are sick, those guys all look well. In there might be one person I have to worry about. How do I identify that person? Now, the old standard approach was take that entire group and be safe and admit them all to the hospital. And that obviously is not a great approach, because a hospital is not a good place for people. And what's more, if it was a bad arrhythmia, 2 days in the hospital may not find it, and then they go home and then they die, because they had it. So the question now is, how do you approach those patients? And that's what this chapter talks a little bit about. Number 4 is about predictors of outcome in syncope. Who are the ones who come back sick? Very few come back sick. Of the ones who come back sick, guess what? It's old people with risk for heart disease. Duh. But the interesting thing is that there are certain types of heart disease that can be bad, like valvular disease, which are actually more in young people. So throw out what I just said. It doesn't matter, old people, heart disease. The really bad ones, including VTAC, are often in young people. Number 5 says we do zillions of tests. And number 6 says they don't give us any useful information, especially head CT scans. If you have something in your head that I'm going to find on a CT that caused your syncope, you are not normal. Why we do all these head CTs and syncope, I don't know. What we should be thinking about is an arrhythmia. We should do a good neurologic exam. If they're not normal, that's entirely different. But somebody who's completely, they were normal, they passed out, now they're back to normal, that's not a problem in the brain, it's a problem of something that affected the brain, and that the one that we have to worry about is an arrhythmia. So, what kinds of things can we do to find the arrhythmias? Right, so we take a pulse, right? We evaluate them right in front of us. But they're normal. So what are the things that what are some clues we could get? It's really pretty easy. What's the really important test to do? An EKG, okay? And what are you looking for in an EKG? Again, I want to see something that will trip me off to the idea that, whoa, there might have been a big arrhythmia. It's not going on now. I'm not going to see it on the monitor, but I might see a clue on the EKG. What could I see? I could see a long QT. That's probably the most important. Now, how long is long? There's no answer. Either you make it very long, in which case you're non-sensitive, but you are specific. It's so long that it's really worrisome, but it doesn't pick up a lot of them. Or you make it so short that, oh, it's a little long, that it'll pick up all the people who have an arrhythmia, but it will pick up a billion others. So the answer is, looks long to me. That's the best I can tell you. That's what the literature says. There is no right answer. But if you see an EKG where there's a long QT, it should trip your mind that maybe this was a ventricular arrhythmia. So it's something to look for, and it's not great. It's not going to predict very well. But again, this is a state we're looking for that life-threatening disease in a very few people. If you see a significantly long QT, that's somebody who needs more attention. What else can you see on an EKG? So there's 3 articles on long QT in here. What else? WPW, it's not in this chapter, I don't know why, because there are articles on it. It's an important thing. If you see WPW, that means they're very, very, very increased risk for tachyarrhythmias. Now, usually the tachyarrhythmias are benign. It's SVT. But every once in a while, somebody with WPW gets a not so benign tachyarrhythmia. What's that? AFib. And particularly, AFib is a real problem in these people because it goes down the wrong pathway. Remember, AFib is the atrium going off like crazy, 600 times a minute. And the good news is that your AV node blocks it down, so you can't go more than 150 times a minute. But they have a fast pathway that can go 220. In 220, you can pass out. Not only that, you can trip off VTAC and VFib. So it's an important one. If you see a delta wave in a short PR in somebody who came in with syncope, that's a big deal. Those need important referral. And then the third thing you see on the EKG is in your chapter, and I'm only mostly going to debunk it, even though I don't want to completely debunk it. It's Brugada syndrome. And here's why I'm going to debunk it, okay? The chapter says up to 60% of sudden deaths in Asia may be caused by Brugada syndrome. That's what it says. That's what there's literature out there that says that based on a couple of reports. Why is that impossible? Who was here 25 years ago? I don't want to point fingers. Before there was Brugada syndrome. How could it be that it was in every other patient and no one had ever heard of it? It's just not possible. It can't be. I've been doing this for a long time. It's a really weird looking EKG. If it were there every time somebody was passing out, it's hard to imagine that none of us would ever have known anything about it. So there's a good paper here which says why that probably is true. And that is number 12. They followed people who had Brugada syndrome. There were 212 of them. Now there's two different ways of having Brugada syndrome. It's sort of like having ST elevation MI. Let's go back from Brugada syndrome for a second and talk about a STEMI. What's a STEMI? How do you define a STEMI? That's an important one. How do we define it?
ST elevation greater than 1 millimeter, 2
So,
adjacent leads.
Great. So there are criteria you could use: greater than 1 millimeter, 2 adjacent leads, in a pattern, blah, blah, blah. That's one definition of STEMI. There's another definition of STEMI, which is I walk in the room, I see somebody who's going to die. And then I look at the EKG and there's tombstones on it. Those are two very different things. A STEMI, a clinical STEMI, is an obvious event. There is no such thing as a clinical STEMI who looks well. You walk in the room, oh my God, doesn't matter what the EKG shows. And then the EKG, oh yeah, look at that, it's got these huge tombstones. There's another type of STEMI, which is the patient was fine, got sent home, something happened, and now we're doing a quality improvement review, and we go back and look at the EKG and we say, look at that, see, look at that, there was 1 millimeter elevation right there. How did they miss it? But there's 1 million patients who have 1 millimeter elevation. And so using these sort of retrospectoscope definitions to ascribe blame is a problem that we in emergency medicine have a lot, because people look at our stuff and say, how come you missed that? But that's a very different thing. So Brugada syndrome also takes different forms. It takes the form of, there are actually people who die from this. But there are also people where you look at the EKG and you say, you know, I think that's sort of like right bundly. What do you think? Oh yeah, let's call it Brugada syndrome. Those are different things. So number 12 says, we found all these patients with Brugada syndrome. Only 10% of them were discovered because they had had a critical arrhythmia. And when they followed those people who had survived a critical arrhythmia, 20% of them had a recurrent critical arrhythmia in the next couple of years. That was a very small group, and the risk was high. Then they had some people who had had a syncopal episode, and somebody said, you know, I think that's Brugada. And about 5% of them had a recurrent event over the next few years. And then they had people where it was defined purely by EKG. Somebody did an EKG, they said, oh, look at that, I think that's Brugada, or some family thing, and they followed them. And how many of them had an event? 1%, almost zero, less than 1%. So I think we got to keep in mind a clinical event, and look at the EKG, and oh yeah, I noticed this. If somebody comes in with real syncope and you see real Brugada, that's important. But let's not get over the top about this. There's a lot of things where you could look at an EKG, you read 1 billion EKGs, you could call this, and most of them are meaningless. Now, since we're talking about syncope, if you get an EKG in syncope and you see Brugada syndrome, true ST elevation in V1 with a right bundle pattern, that needs urgent referral, because he's already identified himself as having the real deal. Those are the important things. The rest of it says, so what do we do? So you get an EKG, it looks normal, are you done? Well, it's sort of like what we talked about, head trauma or dizziness or any of these things, which is, no, they still need follow-up. But the good news is they're fine. They're almost certainly fine. The ones who look fine, you find nothing, they're almost certainly fine. Now, then there are two other things that this mentions. None of this has to do with papers. There are papers which recommend this, like the NICE guidelines, but there's no evidence for anything I'm about to say, which is, if there's an obvious reason for their syncope that's benign, you probably don't have to worry. And you probably don't have to do much of anything. So they were standing up in the sun for 3 hours, and then they got weak, and then they fell down, and now they had something to drink and they feel better. That's probably okay. They went in to get their blood drawn and they went, ooh, they had a little, that's no big deal. Especially if it's a big guy who's always the one who passes out. On the other hand, if there's some other thing that really troubles you about the patient, it's somebody who has bad coronary disease and they have syncope, they need closer attention. Old, bad underlying disease, etc. Other than that, there's no other clues. And that isn't proven. There's no proof of any of that. It's just made up, but it's probably right. So again, I think it's, and the NICE guidelines, you know, the English have this bizarre habit of actually trying to think about things and tell us a good approach to it, which in America is, you know, not allowed, because it infringes upon our civil liberties to have somebody tell us what to think. So the NICE guideline says a little of what I just said. Think about, are they high risk, low risk, etc. And there's a terrible paper about distinguishing cardiac versus vasovagal syncope, so I'm not going to tell you about it. That's number 14. Ignore it. Draw big black lines through it. And, oh, the last one is syncope decision rules. And one of my soapboxes is decision rules. So first of all, they shouldn't be called rules. They should be called something else, right? Because they're not a rule. There is no such thing as a rule. A rule you must follow. So a decision instrument like Nexus is a way to help you think about something. But if you think differently, for whatever reason you're concerned about a patient, ignore it. Okay, so I don't like calling it a rule. Call it a decision instrument. I believe that Nexus is a really good decision instrument for how to decide when a patient doesn't need a neck x-ray. I'm pretty sure it works. But I think it works only because it tells you what you already knew. Because it's obvious. Nobody actually needed to know that if a patient doesn't hurt on their neck, and they're not altered, and they're not distracted by something else, and they can talk to you, and it's fine, they're fine. I don't think we need to know that. We all knew that. We just were afraid to do it because you don't want to miss a neck thing. So the nice thing about studying it was saying, you know what, it turns out it works. But it wasn't because it was some brilliant thing. Oh my God, if it's a Tuesday and they have 4 letters in their last name, nothing like that. It's stuff we all know. Decision instruments work when they verify, confirm what we really already know. But in addition, I believe they only work for very simple yes/no clinical questions. So for example, how many ways can you tell me that you've broken your neck? Think about it for a second. What are the clinical manifestations of breaking your neck? Well, it hurts, right? Either it hurts or I can't talk to you. I'm altered in some way or other. I'm distracted, something else is going on. Oh, I could show neurologic findings. But other than that, how many ways can you tell me you have a broken ankle? It hurts when you press on it and you can't put weight on it. That's about it. That's why the auto ankle rule works. Now, we have a few decision instruments for little things like that. Yes, no questions, where, you know what, if it isn't one of those things, don't worry about it. How many ways can you tell me you have having a heart attack? A million ways, right? You could be altered, you could have chest pain, you could have shortness of breath, you could have abdominal pain, you could be nauseated. There's a lot of ways that a heart attack expresses itself. That's why, guess what? There are 93 heart attack rules, each of which have 3 or 4 versions of themselves, and none of them end up working. How many ways can you tell me you have a stroke? A zillion ways. All these stroke rules and ABCD2 scores and ABCD 3A and 3I scores. Anytime a decision instrument has multiple versions of itself, it's proving to you that it doesn't work. And I'll just tell you the way decision instruments are created, because I've done this. You take a whole bunch of data and you torture it. And you find what is the best pattern that comes out of it. And so whatever you do that first time is going to work really well, because that's how you created the decision instrument. You found the pattern that works very well. Now the key is to go do it again in a different population and see if it still works. If the next time you have to say, well, not exactly that, let's just change this one, let's call it ABCD2. Means ABCD didn't work in the second one. It also means that ABCD2 didn't work in the original one, or that's what they would have used. So when you have multiple iterations of the Goldman rule for chest pain, it can't be right. And of course, theoretically, conceptually, it can't be right either, because it's too hard to know, to make a rule for PE or for heart disease, et cetera, which is why I believe the Wells criteria, the objective Wells criteria, works a little worse than clinical judgment. And in the United States and Canada, 2% of low-risk patients have the disease, and in Europe, 20% of low-risk patients have the disease with the same objective score. Can't be. Can't be. So this says, what about the syncope rules? And guess what it says about them? They worked really well when they were first created. That's by definition. When other people look at them, they don't work at all. And they have the following characteristic, which all medicine tests have, which is you can create a version of it that's very sensitive, picks up all the people with the disease, but if you want it to be sensitive, it's completely non-specific. It picks up everybody. You can also make it much more specific, but then it misses everybody. They just don't work. And I'm not surprised they don't work. How could you have a simple rule that's going to tell you all the manifestations of bad syncope, of arrhythmias? I don't think it's possible. So that's what this says. Use judgment and keep, I want to encourage you again to think not only about finding that needle in the haystack, but also about the harm of over-admitting everybody who's old who had anything because you don't want to miss something, because there is a lot of harm from that. And the bad news for us is that if we put ourselves first, we just admit everybody, because we'll never get blamed for that, and we will get blamed for the one we missed. But if we put the patient first, we can't do that. And we're supposed to put the patient first.